Good morning. Welcome to session 309, Challenging Cases in Pediatrics, Pearls and Pitfalls. I have the pleasure of introducing Dr. Kathleen Jordan. She holds dual board certification as a family nurse practitioner and an emergency nurse practitioner. She is also a certified sexual health nurse examiner for pediatrics. She is currently employed as a clinical assistant professor at the University of North Carolina at Charlotte, UNCC, teaching in both the DNP and FNP programs, coordinating the pediatric component of the FNP program. She is also employed as a nurse practitioner at Mid-Atlantic Emergency Medicine Associate, Charlotte, North Carolina, and works in the Pediatric Emergency Department at Nonvent Health Presbyterian Medical Center. She has had multiple publications and presentations at national and international conferences. I am also delighted to let you know that she has recently published a book called Pediatric Emergent, Urgent, and Ambulatory Care, a manual for nurse practitioners. It's published by Springer, and it's just been published this year, 2016. I have some housekeeping. Please turn your electronics onto stun. If you are attending with young children, please bring them to me and we'll try and help them to have fun. Posters on the Move is open from 7A to 7P today, and today's the last day for that. The business meeting breakfast is tomorrow from 8 to 9:05, and tickets are required. For those for those registered for the general session lunch today from 12 to 1:30, we look forward to seeing you there. Please present your ticket at the door. Saturday, tomorrow at 6:30, there's the Zumba fundraiser, and they are accepting registrations after this session. Please give a warm welcome to Dr. Kathleen Jordan.
Good morning, everyone. Thank you for being here. It's such a nice Friday morning. Are you all having a great time in Atlanta? Such a great city. I'm excited to be with you this morning and talk about some challenging cases. I've worked in emergency medicine for 35 years, and I've always worked in big academic trauma centers where we see lots and lots of kids with very common conditions, and then we see our outliers. So what I'm going to talk about today are the outliers, the high-risk kids with common chief complaints that end up with not so common diagnosis and diagnoses that you cannot miss. I have nothing to disclose. The learning objectives basically are written for you, but what we want to do is go through the clinical diagnostic decision-making process on some common high-risk clinical situations to help you work through what you need to think about, what clinical conditions you can't miss, and that's the clue. I want to start out with the way we all feel when we're working, tranquility in pediatric practice. Right? We all feel 100% composed, we're supportive, we feel that everything is under control, every patient's differential diagnosis is complete and all-inclusive, all our interventions are complete and inclusive, there's no errors, there's no medication errors, and as you know with kids, that's the biggest area for errors. Our disposition is always correct 100% of the time. And on top of all that, all of our patients and their families are 100% satisfied with our remarkable care, right? I thought about that last week. I picked up an extra shift, and you know, for all of you that pick up extra shifts, it's always a good idea at the time. And then you're there, and it was like 9 o'clock on Saturday night, and I looked at our track board. We had every room in the Peds ED filled, and there was 25 kids in the waiting room waiting to come back, and there was 2 providers, a physician and myself. And I thought, yeah, we're all under control here. What's the reality? Well, the reality of that we work with high-risk kids. We work with a high-risk situation. Pediatric emergency care is a high-risk environment, and seriously ill pediatric population is the most at risk for medical error. And here's our real life. We're under a time pressure. We're there 24/7. We don't have time to reset and restore. Our personal circadian rhythm is challenged. We're overcrowded. We have unscheduled care. We're with high-risk, high-acuity patients. there's lots of room for miscommunication. And one of the biggest areas for miscommunication is our provider handoffs. So think about that and think about how that places us in a high-risk situation. For a minute, I want to talk about just the evidence-based clinical decision-making process, because every patient we see, we need to ask ourselves, what do we know and what do we need to know? And we need to consider the age-appropriate clinical decision-making process in the diagnoses that are most appropriate for that particular age group. So when you think about your clinical decision-making process, you have to start to think, what is the most likely diagnosis that this child has? And start with the most common, because it is the most common, and then narrow it down to the least common. But you always need to think about what you cannot miss with each child. I don't mean to promote a book that two of my colleagues and I just wrote, but we took that approach. We took a chief complaint-driven approach for every chief complaint that you'll see with children, and we went through the clinical decision-making process, and at the end, in bold, we have what can't you miss? Because you have to think about that. Even with a cough or with vomiting, and that's what we're going to talk about today. What can't we miss? What are those high-risk situations? What do we need to do to really rule out those bad disorders? And in our medical documentation, we need to document that. So I work with, as many of you probably do, with Epic. And and we have Dragon that you can dictate to, so we don't have to do all that typing. It's really very quick. It's very efficient. I'm one of the people that really, really like Epic and like Dragon. But there's the area at the end after our H&P where I always document on kids who will be in the emergency department for any length of time, who I'll be doing interventions and repeated evaluations on, my medical decision-making / emergency department course, and then I start. And what I put in there starting out is what I'm thinking and why I'm thinking what I'm thinking. For example, if I have a 2-year-old that comes in injured and the history is consistent with the physical examination and the mechanism of injury, there's no underlying injuries, I can simply put a statement to that effect in there. And therefore, I can say, doubt maltreatment. If you have a child with vomiting and abdominal pain, you can put in X, Y, and Z, doubt intussusception, doubt appendicitis. But you want to document your clinical decision-making process and why you know that they're really bad diseases you've ruled out. You want to document that you've thought about it and ruled them out. And then you want to ask yourself, are additional tests really necessary? I'm not a big test orderer, because if it doesn't give me the information I need for my clinical validation and my clinical decision-making skills, I don't order a test just to order it. I order a test only if it's going to help me arrive at a diagnosis or management. In today's world, we need to think about the cost of test, and is doing a test going to be of any benefit to us? Luckily, with children, the passage of time is a great diagnostic tool, because you can have a child that comes in that's clinically dehydrated, and you can give them some Zofran and some PO fluid, and in an hour, they're much happier. They're watching TV, they're coloring. I had a little girl just a week ago. She was very dry. She's had, I don't know if all of you have had, but we have had so much gastroenteritis for the past 6 to 8 weeks. It's vomiting and diarrhea, vomiting and diarrhea, vomiting and diarrhea, interspersed with cough and wheeze, cough and wheeze, cough and wheeze. That's my life. So, but anyway, so she was really dry to the point that she needed IV hydration, which I really never do. I mean, she hadn't voided in almost 24 hours. She was lethargic. So we gave her a bolus at 20 cc per kilo. I gave her some IV Zofran, and I walked back in there, and she sat right up, and she said, "You are a good doctor. Just look at me now." She was so cute. But again, consider the passage of time, because that's a great diagnostic tool for us with children. So we're going to go through some cases today with common chief complaints, and we're going to talk about the clinical decision-making process and talk about how we derive at the diagnosis and what the treatment plan would be. So case number 1 is an 18-month-old that comes in with a case of vomiting. Another vomiting and diarrhea, vomiting and diarrhea. So what's different about this? Well, she's 18 months old. Mom tells me that she was called from daycare, and the daycare provider told her that she's been vomiting and she doesn't feel good. So mom went and picked her up and brought her right to the urgent care center. Just like lots of parents pick up a child at daycare, they have a fever, they come right to the emergency department. And I'll say, so what did you do about the fever? Well, I just came right here. So she went to urgent care. Urgent care told her that she had gastroenteritis. The child had vomited 3 times. So what's wrong with that picture? That's not gastroenteritis. Gastroenteritis is a very misnomer. You have to have vomiting and diarrhea. So it's a diagnosis that's used many times inappropriately. So when I walked in the patient's room, the child was laying in mom's arms asleep. And mom said, you know, she's just really, really sleepy. And then every once in a while she wakes up and cries out and says, my tummy hurts. And she, like I say, went to urgent care. Her vital signs were normal. She wasn't febrile. On exam, her mucous membranes were moist. She looked like a child that you would expect to be acutely dehydrated at a moderate to severe level. She was that sleepy. And she'd only been sick for a few hours. So the red light goes off in my head. Something's wrong with this child. This is not just a routine viral gastritis. Her tummy was soft. She had hypoactive bowel sounds. The rest of her exam was totally unremarkable. By past medical history, she was healthy and all her immunizations were up to date. So how do we approach a child with vomiting using a clinical decision-making process? Because we see vomiting all the time. It's a very, very common chief complaint, and it can reflect many body systems. It can be GI, it can be neuro, it can be renal, it can be psychiatric. Most cases of vomiting are determined basically by a good history and our physical examination, and we don't need diagnostic tests in the majority of vomiting. My philosophy on a CBC in a case like this is don't do it and don't chase it. So if you get it, I don't know why you would get it, but if you do, don't try to find out why they've got a white count of 11,000. Don't chase it, because it's just going to be more tests, and you're still going to come up with nothing. So look at your medical history, look at your clinical presentation, look at it, see if there's any complications, hemodynamic challenges, neurostatus, and think about the disorders that are most common to a particular age group. What are our red flags with vomiting? When do we start to get concerned? Well, if you have a neonate that's been vomiting for over 12 hours, that's concerning. A child under the age of 2 that's been vomiting for over 24 hours, that's concerning. Over 2 days in an older child. Lethargy out of proportion to the illness. So here we have a sleepy child who's been sleepy since mom picked her up, wakes up intermittently. When you look at her and look at her mental status, you would expect the child to be clinically dehydrated because that's the way she's acting. But yet she's not. She's voiding. Her mucous membranes are moist. Other red flags are bilious vomiting. Parents will tell you he vomited bile. Bile is green. Ask any surgeon. Bile is not the yellow stomach contents that children vomit. It's pure green emesis. If you have projectile vomiting in an infant younger than 6 weeks of age, of course, that's concerning. Anytime you have blood in the emesis or blood in the stool, other concerning signs. And of course, if their tummies are distended, if they're tender, if you have decreased or absent bowel sounds, we worry about that. Other non-GI complaints, if you have a bulging fontanelle, if the child has a headache associated with vomiting or head trauma, and if they're hypotensive. Differential diagnosis in your medical decision-making process. In your neonates and young infants, you can have reflux. Lots of kids have reflux. It's very, very common. Pyloric stenosis, again, if the parent tells you he's vomiting forcefully, you want to really clarify that. Is he vomiting across the room, or is he just spitting up and it's dribbling down the front of him? Think about obstruction. Sepsis. Many neonates present just with vomiting and they're septic. Excessive feeding volume. Does it not amaze you how much parents will feed children? I mean, you have a 2-week-old and they're telling you they're giving him 6 ounces every 3 hours, but he's vomiting all the time. So hydrocephalus, of course, is something you need to think about with increased intracranial pressure and then the whole inborn error of metabolism. Older kids, older infants, And children, think about early gastroenteritis, infection, intussusception, constipation. It's amazing how many children's parents will seek medical attention, particularly in an emergency department for constipation. Elevated ICP, cyclic vomiting, migraine, and factitious disorder by proxy. There's case studies out there where parents give their children Ipecac just to seek medical care. Then in adolescence, you can see dyspepsia, APIs, irritable or infectious or inflammatory bowel disease, pregnancy, or anorexics and bulimics, psychogenic vomiting, and rumination syndrome, which basically they'll tell you I threw up in my mouth. So let's go back to our little child who comes in with a few hours of vomiting, some intermittent colicky abdominal pain, and decreased activity. What's most concerning? To me, it was her mental status. Her lethargy was out of proportion to the history of the illness. So on my differential, based on that, based on vomiting, based on colicky abdominal pain, and that lethargy just stood right out, intussusception was certainly my number one. And then under that, viral gastritis, constipation, and infection. So in my plan of care, the first thing that I would do was an ultrasound. Of course, she would need fluids and get some routine labs. So with intussusception, you got to think about in your clinical decision-making process, what are you looking for, and what can be reassuring to you that a child does not have an intussusception? Because this is a cannot-miss diagnosis. Inconsolable episodes of crying. She's drawing her legs to her chest, but she's acting normal in terms of between the episodes of pain. She's increasingly lethargic. She has had vomiting, and again, you want to clarify because parents will tell you she's vomiting bile. Again, bile is green. Stools may have a current jelly appearance or bloody stools in their diaper, but this is late. It only occurs in about 10% of children, so don't be reassured if they haven't had any current jelly stools. When you see current jelly stools and bleeding, it's ischemic changes within the intestine. And it's very common for kids to have a history of a viral illness a week or so ahead of time, whether the mom says they've had a tummy bug or they've had a cold, they go to daycare, things like that. On physical exam, there's that lethargy again, decreased or absent bowel sounds. They can have some diffuse pain on palpation. What's actually pretty diagnostic is if you can palpate a sausage mass in the right lower quadrant, because the most common site of an intussusception is where the ileum meets the cecum, where the small intestine and the large intestine join. And if you've ever felt that sausage mass, you'll never forget it, because it's really very distinct. So labs in terms of an intussusception, it's not necessary for diagnosis. It's not going to give you your diagnosis. But in a vomiting child who appears that sick, first of all, you need to get a glucose because vomiting, you know, can be a first sign of DKA. So you got to think down that path because that, again, is a cannot miss. So I got a glucose, a CBC with diff. You can get a BMP or a CMP. I did the ultrasound because I just know from seeing many, many kids with experience, it really is the most efficient and effective test. It has 100% sensitivity and specificity. You can do a KUB or an upright abdomen, but it's only going to be accurate in about 25% of the cases. And you still may need to go back and do the ultrasound. An ultrasound is no radiation. It's painless. In our center, we can get them done within minutes. So just go ahead and order the ultrasound. A barium enema can also be diagnostic if you're highly suspicious of an intussusception. The treatment of intussusception, it really depends on your radiologist. You can either do barium or you can do an air enema because basically the puffs of air will force the intestine out. And I always call pediatric surgeon if I have an intussusception that's going over for an enema, just to let them know and give them a heads up that I may be needing them later. First of all, the child, number one, regardless of the effectiveness of the barium enema or air enema, is going to be admitted for 24 to 48 hours because 10% of these intussusceptions can reoccur. And if it doesn't work, they may need to have intraoperative reduction, or if there's a perforation, they need surgery. So I give our pediatric surgeons a courtesy call. This little girl had a barium enema. It was reduced. She did really well. She came back from radiology. She was smiling. She went up to the peds regular floor and was discharged in a day and a half. So the clinical pearls for intussusception that you need to know so you do not miss this, it's lethargy out of proportion. In 35 years of emergency practice, I have never seen a child with an intussusception running around the room. They're always lethargic. And it's varying level of, some can be just sleepy, others can be truly lethargic. Their episodes of crying, the mom will tell you they're severe and they're different from a normal cry, like something's really hurting them. They have a history of a viral illness in the past week to 10 days. Current jelly stools or bloody stools in their diaper, it may be present, but don't wait for it and don't hang your hat on it, because it's a late sign and it doesn't occur with everybody. And then remember, they have to be admitted because there is a small percentage of recurrence. Our next case is vomiting in a 6-week-old. This is one of those cases, and I'm sure that you can all remember, that I will remember for the rest of my life. A 6-month-old was brought into the emergency department with chief complaint of vomiting. I walked into the room, and there's a very young dad and a very young mom. Mom worked in a fast food restaurant. She still had her uniform on. And I walked in, and I said, how are you? I'm Kathy Jordan. I'm the nurse practitioner. And the dad stood up and met me as I was walking in the room, put his hand out, and said, how do you do? I'm Sam Jones, obviously not his real name. I'm Sam Jones Sr., and this is my pride and joy. This is Sam Jones Jr., and I'm his proud daddy. And I looked at him, and I remember saying, as like it was 5 minutes ago, you are a proud daddy. I love to see that. And I sat down and I started getting the history. And the history was the child has repetitive vomiting. They've been seen by their pediatrician. The first thing was he had formula intolerance, so they switched the formula. The child had continued to vomit, so went back to the pediatrician, and the pediatrician just told them, I'm really sorry, some kids are just really fussy. And this is a fussy baby. We call that colic. And the babies cry a lot. So the mother took the baby home thinking that, okay, the soy formula is going to work and I'm just going to have a baby that cries a lot. The child was afebrile, it was non-toxic appearing, sleeping quietly in his arms. So I'm sitting on my little black stool and I stand up and I walk over to the baby and the mom and I put my hand lightly on his anterior fontanelle. And truly, I've never seen a child react like this. He screamed and was flailing his arms and legs, and I just basically touched him. And I remember thinking to myself, this child isn't febrile. I said, maybe he's just really hungry. I said, well, let's try to see if we can calm him with a little Pedialyte. So I went out and got some Pedialyte, and I took the baby myself, and I was feeding the baby some Pedialyte, and he calmed down, and he was sucking. And I asked the mom to sit on the stretcher, and I put the baby back in her arms, and I touched his head again, and that was the same reaction. Screaming, crying, flailing his arms. The rest of his physical exam was normal. So what kind of things do you want to know from a mom with a vomiting infant? Well, when was the child last well? And I usually ask them, when you put him to bed last night or when you got him up for his last feed, did he act like he was sick then? What's the first thing that you noticed that concerned you? Was it his level of alertness? Was he more fussy? Did he have any episodes where he kind of got pale and limp? Did he get any blueness around his mouth? What was his motor activity like? So you want to just kind of keep your differential very, very broad at this time, even though in my heart and in my head, I knew this isn't going to have a good outcome. And I remember going out to the nurse and say, can you take a repeat temp on him? Because I thought to myself, you know what? I would really much rather put a spinal needle in this child's back and do an LP and do a septic workup than go down the path I think I'm going down. So on exam, again, he was very irritable. And I never use the term irritability. I shouldn't say never, but I rarely use that term. I say fussy or lethargic, but irritability to me carries a very strong connotation. This child was irritable with a capital I. He was afebrile. The nurse did a repeat rectal temp. His anterior fontanelle was full. He became more irritable every time I touched his skin and his head. And so my differential diagnosis of all the things I wanted it to be, my number one was abusive head trauma. Other things you can think about with a vomiting infant would be reflux, pyloric stenosis, again with projectile vomiting, obstruction and sepsis, excessive feeding volume. So unfortunately, in terms of my plan of care, I got a stat brain CT. But other things I knew that were coming down the line would be baseline labs. With concern for abusive head trauma, there was a great protocol by the American Academy of Pediatrics that advises us to get a CBC. You want a CMP because you want your LFTs, because your decision whether or not to do a CT scan of the chest and abdomen is going to depend on LFT elevation, because you don't want to put kids through a scanner and all that radiation if you don't need to. And then, of course, your consults. You need to think about your social worker and your DSS and law enforcement, ophthalmology, neurosurge, et cetera. So he went over to CT. His IAV had been started. Bloods had been drawn. And within a few minutes, our secretary paged me to pick up line 2 because the radiologist was on the phone. And you know what? In my heart, I knew. I just said, this is going to be it. And how many of you have radiologists that call you with good news? They don't. I said to one of our radiologists, and I've worked with these radiologists for almost 20 years, I said, will you just call me sometime to ask me if I'm having a good day? Because every time I hear radiologist is on the phone for you, it's never good news. So what his exact words to me were, Kathy, it doesn't get any worse than this. He had a parietal skull fracture. He had a cerebral contusion with hemorrhage, chronic bilateral subdurals, and then on the skeletal survey he had a healing humerus fracture. So knowing what I knew about this father and this overbearing, concerning, I'm the dad of the year, I waited until the police got there before I went and talked to him, because just dealing with so much child maltreatment, I know how to pick up a parent that's going to want to corroborate a story with the woman that was in the room. They had to get their story clear. So once the police got there, I went in the room, I turned off the TV, I got on my famous little black stool, I went right up to them and I said, you know what, I don't know when this happened or how this happened, but your son has got a very serious brain injury. And the father started, oh, I shouldn't have brought him here, and I shouldn't have left him with cousins Joe, et cetera, et cetera. And the next thing, he said, well, can we just lay him down because we're going to go outside and have a cigarette? And I said, well, you can't do it, because I knew that's what they wanted to do. I said, you can't do that right now, because I opened the door and the police walked in. And they were just like. So the police interviewed the mother in one of our conference rooms, brought her back, and brought the father downtown to interview him, and he never came back. So, I mean, he was charged with felony child abuse. So unfortunately, it gets sadder. So this was a Saturday night. I went back to work on Monday, and I called the PICU just to see how he was doing. And he was starting to wake up. He wasn't quite as fussy. He was taking PO well. And I said, has he had a lot of visitors? And the response was, not even a phone call. No one even called to check on this child. So about 2 weeks later, I got subpoenaed to go to DSS court for a custody hearing. And then I got called that the parents had just relinquished custody. And come to find out, they had an 18-month-old taken away from them out of their custody in permanent foster placement about 8 months earlier. So sad, really sad. So what do we need to think about with abusive head trauma? We need to be very astute in getting our history, because we miss so much of it. 30% are misdiagnosed at their initial presentation. We had a child 2 weeks ago who had been seen by their PCP twice in the prior week, was seen at an outlying emergency department. This was a Saturday. That Saturday morning, was discharged with reflux on Zantac, and about 2 hours later, Mom was holding him when he started to seize, and he came into us seizing and unresponsive. So we're missing it. 40% or more of deaths due to child maltreatment are due to abusive head trauma. And so many times the symptoms are so nonspecific with no external sign. This child didn't have a mark on him. It can be inflicted by shaking or by throwing. This child had a skull fracture, so not only was he shaken, but he obviously was thrown to fracture his skull. Do you know how long it takes to cause irreversible brain damage of an infant with shaking? Like 3 seconds. So it doesn't take much. And the physical findings, again, can be very, very nonspecific. Case number 3, this was a very interesting case. This was a 3-year-old that had been sick at home with vomiting, diarrhea, fever, and abdominal pain. And he was getting sicker. So mom took him to his primary care physician that morning, and he really looked sick. He looked really dry. So he sent him to us with the diagnosis of gastroenteritis with dehydration. So when I went in the room, he was febrile to 102.3. He was sitting on mom's lap. He looked very clinically dehydrated. He was dry. He was just fussy and very, very quiet and just kind of moaning. He was pale. So as I got closer to him, he got a little more awake, enough to say, no, don't touch me. So we'll talk about how to approach a child like that, especially to approach, kids scream and yell and kick, and if they're healthy, if they're in for, a sore throat or an earache, that's one thing. But when you have a child that is this acutely ill, we need to be very cautious in how we approach them. So anyways, on exam, he did have a red throat. His tonsils were big, and lots of 3-year-olds have big tonsils. His lungs were clear. He was tachycardic. His abdomen showed virtually absent bowel sounds. And every time I went to touch his little tummy, he would push my hand away and say, no, no, no. So how do we approach a child like this? My feeling is do anything I can to keep the child happy. So I'd let the child just stay in the mom's arms. Sometimes I'll have the mom just lay on the stretcher, and if I need the child to be laying down, I'll have the child just lay on the mom's chest. One thing you can do to check for peritoneal irritation is take your ophthalmoscope or your otoscope and say, let's see if we can blow out the candle, and have the child blow. Because if he has peritoneal irritation, when his diaphragm lowers, when he blows out, it's going to hurt. I'm all about minimizing any pain you can. And it just makes me cringe if you see people walk into a child with abdominal pain and they want to assess for rebound tenderness and they mash down on their belly and let up. You don't need to do that. You can be very gentle and make a clinical decision that he's got peritoneal irritation. You can let the child sit there and just kind of roll his hips a little bit. You can lightly percuss on their tummy or have mom just jump them up and down in her lap. If they've got peritoneal irritation, that's going to hurt. They're going to say stop. A lot of questions I'll ask older kids, when you were driving to the hospital with your mom, when she went over the bumps in the car, did it hurt? So you don't need to mash on their belly and let up on an inflamed peritoneum. And don't ever forget the genitals. Remember, in terms of torsion, we got the big incidence during infancy and then in adolescence. So genitals are part of the abdominal exam. In terms of lab tests with abdominal pain, 25% of kids with gastroenteritis are going to have an elevated white blood cell count. So what are you going to do with that when you get back a white blood cell count of 14,000? How is that going to help you in your clinical decision making? It's really not. So my philosophy is don't do it, don't chase it. Even kids with an acute appendicitis may have a normal white blood cell count, unless, of course, they're perforated. The best test to do if you're concerned about a perfed appy would be a CRP. We do a lot of CRPs in my center. Of course, you want to do a point-of-care glucose at a minimum because, again, abdominal pain and vomiting can be the first sign associated with DKA. Or if you have a child who's acutely dehydrated, you want to make sure they're not hypoglycemic. BMP, because I rely heavily on looking at their CO2 levels to see if they're dry. And then a UA to rule out, obviously, UTI, and also you can see what their urine looks like for DKA. Imaging, if you need imaging, and you don't need it very often in children, ultrasound, especially for an acute appendicitis, would be your number one test of choice. I rarely, if ever, do an abdominal CT on a child unless it's trauma. If I feel a CT is indicated on a child, I usually talk to my pediatric surgeons first. Because truly, the philosophy with the surgeons I work for is we don't need CTs. We're exposing them to unnecessary harmful radiation, and they get really upset if we just arbitrarily order CT scans on patients. So the risk of cancer for an abdominal CT is really 1 in 1,000. So unless it's a trauma patient, I don't do CTs without talking to a pediatric surgeon. In terms of your differential and your do not miss diagnosis, gastroenteritis is usually the #1 diagnosis with abdominal pain. But remember, gastroenteritis can cover up other more serious diagnoses. By gastroenteritis, I mean vomiting and diarrhea. And you can have that with other more serious diagnoses, so don't rest your hat on that. Don't be falsely reassured and say he's got gastroenteritis, unless you're sure he has gastroenteritis. Unless you've gone through that clinical decision-making process and thought about what are the really bad things, and do they have any signs of those that I cannot miss. Respiratory and tract infections, lots of kids with pneumonia will have abdominal pain and vomiting, of course, then UTI, constipation, and a nappy. In terms of your medical decision making, obviously he was very, very dry, so we started an IV, peripheral IV with crystalloid fluid at 20 cc's per kilo. And again, you can repeat that once or twice. Zofran, I love Zofran, and it's very, very safe. We give it to young infants in the emergency department, and so we gave him some Zofran. He was sick enough that I did a full workup with a CBC, a CMP, a CRP, urinalysis, a rapid strep, just because he did have a red throat. And then I thought about imaging. I thought, is this truly a gastroenteritis with dehydration, or does this child have an intra-abdominal process that we're missing? So I observed him for a while. I knew he would be admitted. When a child comes in that sick, we can't turn him around that quickly. So I went back and reevaluated him, and he was still, his tummy was tender. And I thought, you know what? I'm going to just do an ultrasound. So I did that. And what the ultrasound showed in this 3-year-old, that he had a non-compressible 9mm hyperemic thick appendix with surrounding free fluid, periappendiceal abscess, and loss of the echogenic submucosal layer, consistent with a ruptured appendix in a 3-year-old. I mean, how often do you see that? It's really, really rare. The picture on your lower right-hand corner is a picture of an inflamed appendix. I have to say, I think the appendix is one of the ugliest organs we have in our body. So acute appendicitis in a young child is really a challenge. You don't see it very often. Less than 5% of kids with an acute appy are under the age of 5. And they have a high incidence of perforation only because we miss it. It's not high in our differential to have a 2-year-old or a 3-year-old with a ruptured appy. They come in sick, they come in febrile, they have more diffuse abdominal pain. They don't have the classic textbook appy that we used to see. They frequently vomit before they have abdominal pain, which is not what the classic appendicitis is. And they have no appetite, and a lot of them have diarrhea, which doesn't, again, go along with an acute appendicitis. This child actually went to the OR, and he went home with a PICC line a couple days after surgery for a few weeks of antibiotics because he had acute peritonitis with ruptured appendix. He was sick. What's our typical appendicitis? And this is what we typically look at. They're older kids, they're teenagers. What happens physiologically is you have an obstruction of the appendiceal lumen. Usually it's a fecalith, or you can have a piece of food even that gets lodged in the appendix, because it's an appendage right off of the intestine. You know, the appendix serves no purpose except to make people sick. And then it gets distended, and then it gets ischemic and inflamed, and it irritates the peritoneum. So your classic textbook picture is that the person will come in with periumbilical abdominal pain, and then it will kind of migrate down to the right lower quadrant. And when they come in, they usually are uncomfortable. They have difficulty walking because their peritoneum is inflamed. They have point tenderness. It hurts to cough. It hurts if you do a heel tap on them, if you ask them to jump up and down. If you ask them, when you're coming over here in the car, when you go on the bumps with mommy, did it hurt? I mean, that to me tells me they've got peritoneal inflammation, so I don't need to be mashing on their tummies. Nausea, anorexia, vomiting occurs after the onset of pain. So that, again, is something you'll want to document, especially if you're saying that this kid does not have an appendicitis, and you can say he's had vomiting and diarrhea for 2 days before the development of pain, therefore doubt appendicitis. Fever and a little bit of diarrhea. Your physical examination is really key to your diagnosis. Right lower quadrant tenderness, rebound. If you just gently tap on their heel, it will hurt. The obturator and iliopsoas sign, again, because of peritoneal inflammation over the appendix. White blood cell count, it's going to be elevated and up to 96%. CRP is a really sensitive indicator if you're concerned about perforation. And remember, you do a urinalysis because it's a routine part of an abdominal pain workup, but 25% of kids will have pyuria without bacteria and without red cells. So it's not a UTI, and it doesn't have that pattern. And then imaging, I don't always image. If I have a clear history and a textbook physical examination, I go right to the surgeon. I don't even do an image, but if I do an image, do an ultrasound, and the way you order an ultrasound is ultrasound to rule out appendicitis. And the ultrasound tech knows to go right in the right lower quadrant. You don't need a whole abdominal ultrasound if you're honing in on the appendix. Oops. So here is an absolutely adorable little, what I call a diva girl. It was another Saturday. I do work more than Saturdays, but these are cases I just remember. And I walk in the room, and she was sitting up on the stretcher, and she had on, you know, the beads in her hair, and glitter on her shirt, and glitter on her shoes, and her nails were all done, and she was just smiling, and she looked great. So I said, so what's going on? And Mom told me that she's been having a tummy ache for a couple days, and she's been saying it hurts in her lower right side. And Mom said, you know, her stomach looks swollen to me in her lower right side. And you know, I mean, we take what parents say very seriously, and I'm thinking, swollen. The nurses in triage had already gotten a white count. I knew it was up a little bit. So I talked to her, and she answered all my questions. I did all of her upper head, ear, eyes, nose, and throat with her sitting there. She looked very comfortable and was very engaging and conversing. And then I went to lay her down so I could feel her tummy. And as I stretched her out, she started to cry and say, my tummy hurts, I can't lay down. So I put the back of the stretcher up, and she was definitely tender in McBurney's point. So I thought, I'm not going to image this kid. I mean, the history points exactly to an appendicitis. So I called our surgeon, and I told him what I had, and he goes, you know, I'm right upstairs in the PICU. I'll come down and take a look. And he went and examined her, and he goes, I totally agree with you. Called the OR. 20 minutes later, she's out the door going to the OR. About an hour and a half later, he comes down. He goes, Kathy, I got to tell you about this case. Look at these pictures. It was a Burkitt's lymphoma. And he said, when she was laying flat, getting inducted under anesthesia, it was swollen. He said, there was a mass there. He said, I didn't know what the heck I was dealing with, and then I opened her up. And that, on the lower part of the screen, that white worm-looking thing, that's her normal appendix. So she had a huge malignant mass in her abdomen. Here's another interesting case. This was a very sweet 16-year-old girl that came in complaining of right upper abdominal pain and vaginal discharge. She was sexually active. Her last period was 2 weeks ago. She said she was playing soccer the other day, and she fell and was kicked in the right upper quadrant. So what we have in terms of our medical decision making is we've got a 16-year-old that looks good, that's hemodynamically stable, that has abdominal pain, has abdominal trauma, and has a vaginal discharge. But she's sitting up, smiling, talking, she looks great. Other than having some right upper quadrant abdominal pain, her whole exam was normal. On pelvic exam, she had some clue cells, but you know, pretty much everybody has clue cells. So CBC was up a little bit at 14.5, CMP, UA, and UPT were all normal. So in terms of clinical decision making, your medical decision making for abdominal trauma in kids, the Pediatric Emergency Care Applied Research Network has provided us with great evidence-based clinical practice guidelines, and I pretty much go by these like a Bible. They've got this study, and we'll talk about head injury study, but they've done some really good work to identify children who are at risk for intra-abdominal injury. So for this particular study, they looked at over 12,000 kids, and they came up with criteria of if the child has none of these symptoms, then you're at very low risk of any significant abdominal trauma, and you can pretty much send them home for observation. So number one was no evidence of abdominal wall trauma or seatbelt sign. So that's physical evidence. She didn't have that. Glasgow-Coma scale greater than 13. Obviously, you have to have a patient who's awake and alert in order to do an assessment on them. No abdominal tenderness. Well, she had abdominal tenderness. No evidence of thoracic wall trauma. That's external trauma. Didn't have any of that. No complaints of abdominal pain. Well, she did have abdominal pain. No decreased breath sounds, and no vomiting. So of these criteria, I can't say she's at low risk because she's got 2 of those criteria present. So I did a CT of her abdomen because she is a trauma, abdominal trauma. When you do a trauma CT, you only need IV contrast. You don't need oral contrast. So it's quick. They can be taken right back to CT. And her diagnosis was a right lower lobe pneumonia. So she said, oh, you know, I haven't really felt good for about a week and a half, and I was coughing a lot, but it doesn't seem to be, I'm not coughing as much. And I did have a fever last week, but I'm feeling better now. So what's the clinical take-home point of this? Don't be distracted. Think about the whole picture. So she was able to go home on oral antibiotics. She did fine. She looked good. Here is another very interesting case. This was a 5-year-old who was at a sleepover. And you know what? Little boys will be little boys. So what they did is they made a fort, and they went up on the second bunk, the top bunk, and they were jumping from the bunk onto the floor. So he landed and came in with an obvious deformity of his right elbow. He was hysterical. He was screaming, "It hurts, don't touch it, I don't want a shot, I don't want a shot." You know, how many times, I do this all the time, I'll go into a patient's room and they're sitting there and they won't look at me and they won't talk to me, and then all of a sudden they'll say, "Are you gonna give me a shot?" I can't tell you how many times I empty my lab coat pocket out. Look, I have no shots. There's nothing there. And then we're best of buds. But he didn't want a shot. I mean, you really couldn't even examine him. He was just hysterical. So we kind of stabilized his elbow, and we wanted to get a weight on him so we could medicate him. So the nurse went to stand him up, and he became pale, diaphoretic, and had a little bit of a syncopal episode. We laid him right back down, and he immediately resolved from that. So we thought, you know what, this is all pain-related. I gave him some intranasal fentanyl. I don't know if any of you use intranasal. I use a lot of intranasal fentanyl and a lot of intranasal Versed. I love that. There's no needles. It works immediately. They don't have to swallow anything and wait an hour. And the most important thing is you don't have to start an IV to give them IV morphine. So it works great. So we gave him some intranasal fentanyl, and we got an X-ray. So here's his X-ray. He had a nasty supracondylar fracture. So he's sitting in the room waiting for orthopedics. He's calm, he's medicated, he's watching TV. And I went in just to reevaluate him and his neurovascular status, and he started telling me his tummy hurts. His vital signs were stable, his belly was soft, but he was tender throughout his abdomen, and he was relaxed. So I thought to myself, he had an unwitnessed fall from about 6 feet, and now he's got belly pain. So what are you going to do with that? So my clinical suspicion for an intra-abdominal injury was pretty high because he was pretty tender all over. And he, like I say, he was calm and relaxed. So I did a full trauma workup with a CBC and a CMP, amylase, lipase, type and screen UA. That's just our trauma lab protocol that we can just click and it's entered. And then I did a FAST survey. A FAST survey is a great tool if you have an ultrasound. And basically, you're looking for blood. If you see blood, you can bypass any other tests and go right to the surgeon. So it's great for unstable patients that you're in a hurry to see if they need to go to the OR. But for a stable patient, if you see blood, you don't have to worry about a CT scan. So I did a FAST survey with an ultrasound. You just look at all 4 quadrants. And I didn't see any blood anywhere, so I had to, because of the abdominal pain, I did a CT scan. And what he told me was, "Oh, by the way, I forgot to tell you, as I was falling off the bed, I bounced off the wooden desk." So he had a grade 2 splenic lac. He didn't need any treatment operatively, was admitted upstairs. They repaired his elbow, and he did really, really well. Again, take home point, don't be distracted. What's the old saying? What's the second most commonly missed fracture? The second one. Because we get focused on that first fracture, especially if it's a significant fracture like a supracondylar, and we can miss another fracture. So don't get distracted. Distracting injuries can get you in a lot of trouble. So in terms of our high-risk differential diagnosis for abdominal pain in kids, any history of trauma, kids with colicky pain, plus or minus change in stools, you've got to think about intussusception in kids younger than the age of 3, bilious vomiting, true bile, true green emesis. In an infant, neonate, you think about malrotation, scrotal tenderness and swelling. Always, always, always consider the genitals as part of the abdominal exam because you never and cannot miss a testicular torsion. Then the 3 Ps with ketones, DKA. Recent mono and abdominal pain, think about a ruptured spleen. Petechial rash to the buttocks, legs with hematuria and proteinuria, think about HSP. And don't be fooled by the appendix because you can have an atypical presentation. Positive pregnancy test in a menstruating female is an ectopic until ruled out. That's another cannot miss. And then don't forget, kids can have adult diagnoses. They can have cholecystitis. They can have kidney stones. They can have incarcerated hernias. Okay, moving on. Friday night under the lights. You know, the kids practice all summer in the heat, and they wait and wait and wait, and finally it's Friday night. It's the first game of the season. They're under the lights. The cheerleaders are there. Their families are there. Their girlfriends are there, and they're in their uniform out on the field. So this is a 16-year-old that collided with another patient at a football game. He was knocked to the ground. It was head-to-head, helmet to helmet. He didn't lose consciousness, but he felt dazed. He remembers what happened, and of course, the first thing he wants to do is get back on the field. And you know, coaches are very, very well educated about second impact trauma and concussion. So the answer was no. No vomiting, no mental status change, and no neck pain. But they said, you need to go to the emergency department because you need a CAT scan. Here's another pediatric head injury. This is a 15-year-old that was playing volleyball the night before. She fell to the ground. She hit her head on the floor, and another player fell on top of her. So this is about 24 hours earlier. She complains of a pretty bad headache. She's a little dizzy and photosensitive. She's sleepy, and she says she has difficulty focusing. She's healthy. She called her doctor, and the mom called the doctor, and the doctor said, go to the emergency department. You need a CAT scan. So she came in, she looked great. Neuro exam was totally normal, discs were sharp, every piece of exam on her, there was no cephalohematoma, ears were great, she looked great. So she came in because, as many people do, they come to the emergency department for a CAT scan. Who needs a CAT scan? Well, what do we know? We know that traumatic brain injury is the leading cause of death and disability in children. We know that there's about 7,400 deaths per year. We see about 600,000 kids a year in our emergency departments with head injury. 50% of these kids will undergo a brain CT, and less than 10% of them will be positive. So the good thing about a CT is it can identify acute traumatic brain injury. We are looking for blood. We can see blood. We can see a skull fracture, especially in preverbal children. What's the bad thing about a CT? Well, each brain CT to a developing brain, and the younger the brain, the more susceptible they are to the harmful effects of radiation, and it's worth about 200 times the amount of radiation in one chest X-ray. For every child that gets a CT of the brain under the age of 1, about 2,000 of them will at some time in their life develop a malignancy, and for kids under 5, it'll be 1 out of 5,000. And for each one of those lethal ones, there'll be 3 non-lethal brain tumors. So, you know, I share this data with parents all the time that come in for their CAT scan because they're just determined. That's why they're here. That's all they're here for. And when I tell them, no, I'm not going to do a CAT scan, and this is why, if you present parents with data, they're much more accepting of your decision to not do a CAT scan when they found out that it's really harmful and not as helpful. So again, the PCARN head trauma study, which is a great study, it was a prospective cohort study, and they looked at 42,000 children throughout the United States. They had 25 pediatric trauma centers that they looked at, and the Glasgow Coma scale was between 14 and 15. So again, you have to have an awake, alert child with normal mental status. 25% of them were under 2. This is how they describe the mechanism of injury. A mild head injury is if you fall from a ground level. So if you've got a 2-year-old who's running to catch a ball and he falls, that's a mild head injury. Moderate head injury, this was their operational definition, anything that's not mild versus anything that's not severe. I guess they got it covered. So severe is a motor vehicle collision with ejection, or death of another passenger, or a rollover. Pedestrian or bike versus auto without a helmet on. In kids, and you always want to ask how far did they fall, because kids under the age of 2, 3 feet is kind of our cutoff. If they fall less than 3 feet, then you need to be more concerned. And over the age of 2, it's 5 feet. So I always want to say, and parents will be like, I don't know, it's off the bed. And I'm like, well, do you have one of those high beds that you have to take stairs to get to? And so try to quantify how far they fell. And then if the head has a collision with a high impact object. So here's the prediction rules. These are reliable and validated for who needs a brain CT. And share these with parents. Kids under the age of 2 or over the age of 2, anybody with altered mental status. Under the age of 2, if they have a palpable skull fracture. So as you're palpating their skull, if you have what we call a step off, you're not feeling smooth cranium. There's a bump there, it's a step off. If they have a hematoma anywhere but the frontal area. Kids commonly fall and they come in with a goose head on their forehead, may or may not have a laceration, and that's low impact, really. The frontal bone is very, very thick and it's very, very strong, and I show parents that the brain is way back here. If you're going to hit your head, that's the place to hit it. If they've been without consciousness for over 5 seconds, or severe mechanism of injury, or not acting right. And again, a diagnostic tool that's very, very useful in pediatrics is just watching them. Tincture of time. And I do that a lot if I'm on the fence about whether or not to order a CT. And when I go in an hour and they're running down the room and they're hungry and their mother's like, please, can you let us go home? He's driving us crazy and he's tearing the room all apart. So I mean, tincture of time. For kids older than 2, any clinical signs of a basilar skull fracture like raccoon's eyes or ecchymosis behind the ear. Again, palpable skull fracture, loss of consciousness for over 30 seconds, vomiting. Not vomiting once or twice, but repetitive vomiting. And again, severe mechanism injury or severe headache. So if you fall into this category, you need a CT scan. The study says that children with no risk factors don't need a CT scan. And again, on our part as nurse practitioners, we need to do a lot of teaching with parents and explain this is why. It's not that where parents think, you know, you're being negligent. My doctor told me to come here for a CT and now you're not going to do it. So you want to just explain this is why. Radiation is dangerous to a developing brain. There was this huge study done, and I show them numbers. Children with either of the 2 high risk factors like altered mental status or evidence of a skull fracture, of course, will need a CT. And if they have any of the 4 predictive risk factors, they're at intermediate risk, and our advice is individualize your CT scan. So basically, tincture of time, watch the child. Observation, again, it's very useful. If you have a scalp hematoma greater than 3 centimeters on anywhere but the frontal area, it's concerning. Loss of consciousness, repeated vomiting, or isolated headache. And then if someone has a seizure after a head injury, that's very concerning with the high incidence of a clinically important brain injury. So, how many of you would CT the football player? How many of you would CT the volleyball player? How many would CT none of the above? I wouldn't CT either one of these kids, because they have a concussion. And we hear a lot about concussion, but the bottom line is a concussion is a functional disorder and not a structural disorder, meaning that imaging is going to be normal with a concussion. So what do you look for? Loss of consciousness. Amnesia is really an important sign of a concussion. Headache is an important sign of a concussion. They can vomit. We can treat that with Zofran. We've had so much media coverage regarding concussions in every single realm of practice, in emergency, in pediatrics, in adult, in sports medicine. But the thing to remember is that a concussion is functional and not structural. So the most important thing is that you need to take them out of play. And I've had kids, especially like young cheerleaders that are going before competition, you know, the flyers that the girls miss and they land on the floor and they hit their head and then they vomit and they have blurred vision and they have a horrible headache. And then you tell them, you know what, you can't go to that competition this weekend. They will sit there and sob. Now, if you tell them, you know what, you really can't go to school for the next couple days, then all of a sudden you're their friend. But so basically, you know, the biggest thing is avoidance of additional head injury because of the second impact. So they have to be taken out of play. And that can be really rough for them. You might as well cut some of their arms off if they're very serious about their athletics. So we put them on what we call neurocognitive rest. So you don't want to do anything that causes them to think a lot. And they're, oh yeah, until you tell them that that means texting, playing video games. You know, you want all of those things that make them feel worse not to be a part of their life. In terms of return to play or return to work, it's not a same-day decision. So my rule of thumb is that they stay home with cognitive rest and they follow up with their primary care physician. Not everybody needs to see a concussion specialist. We have several concussion specialists in Charlotte, but I don't send every single child there. If it's been over a week and they're still having symptoms, then they need to see a concussion specialist and have neurocognitive testing done. So basically the care is symptomatic. They don't need to stay in a dark room. That evidence has found that really hurts them more than helps them, but they need to do moderate activity. The rule of thumb is if they can do something for an hour, then they can go back to school. Now, many times the concussion specialist will put them on a modified academic schedule that they can go to school, but they can't take tests and they can't do their homework, but they can still participate. Most times it's out of their physical activities, though, and it's return to play is after return to work. And there's a stepwise guide that kind of helps us to say, if you can pass this level, then you can move up and on and on and on. So it really works well for management of concussion. This law, if any of you have time, you should look at this video. It will rip your heart out, unfortunately. On the left upper side is a picture of Zachary listed when he was playing football, and he is a second impact head injury. On the right upper side was his picture at his high school graduation with a severe brain injury. He's walking with a walker. So he was a second impact injury. So in 2009, this law was passed everywhere in the United States that if the athlete has to be removed from a game if he has a concussion or suspicion for a concussion. And for those of you that have middle school and high school athletes, I'm sure that the coaches in the beginning of the year or your athletic director will sit down with you and you have to sign a consent that you're aware of this, that you've received the information, because concussion, particularly second impact, is something that we all need to be acutely aware of, and this case is definitely one of them. Whoops. My last case is a prolonged fever in a toddler. This was a little 3-year-old guy that was diagnosed with a viral syndrome that kept getting sicker and sicker. Came into us febrile at 39.5. He looked really ill. He was alert and fussy. His bulbar conjunctiva were injected with limbic sparing. So key number 1, his lips were red. He had a strawberry tongue. He had marked cervical adenopathy. His hands and feet were swollen, and the reason the parents brought him into the emergency department that particular day was because when he tried to get out of bed, he couldn't walk because his feet hurt so much and his ankles hurt so much. And he had a deep erythematous rash. So here's some pictures of the rash and the cracked erythematous lips and the bulbar conjunctivitis and the lymphadenopathy, the strawberry tongue, and his hands. So what's this diagnosis? Kawasaki. Kawasaki is something that we cannot take lightly and we cannot miss. Now, to make the diagnosis of Kawasaki, you have to have 5 of the 6 major criteria: high fever, rash, conjunctivitis, mucous membrane involvement, erythematous induration of the hands and feet, and cervical adenopathy. The major complication of Kawasaki is acquired heart disease, and it's coronary artery aneurysms, which can be fatal. The peak incidence occurs during the second year of life. Male to female is 1 to 5 to 1. The highest incidence is Asians, followed by African Americans, Hispanics, and whites. It can be recurrent. There's really no laboratory study that will definitely tell you this is Kawasaki, so you use the Kawasaki criteria. Again, you have to have 5 out of 6. Of course, you want to look at your CRP and your SED rate, which are both elevated, thrombocytosis, leukocytosis, left shift. You can have elevated LFTs. But here's a picture of a heart with a coronary artery aneurysm. And if not treated with IVIG, then you can develop this aneurysm. And like I say, the biggest complication is that the aneurysm can rupture, and that would be a fatal outcome. So it's something to be aware of. If you have a child that comes in, these kids look sick. Not several years ago, like 18 years ago, we lived in Washington, D.C., and I worked in the emergency department at Georgetown. And we had like 5 kids that winter with Kawasaki post-strep. And so you need to think about that. Look at your criteria. These kids need to be admitted. They need to have IVIG. And they usually do an echocardiogram upon admission. But IVIG is critical. And then they go home and aspirin for months. Thank you very much for your attention. If you have any questions, I'm more than happy to answer them.